So, um, if you uh, reduce the tidal volume, the ventilation reduce, and the patient becomes hypercapnic, right? So, you allow for that hypercapnia is what you call permissive hypercapnia. Do you understand? Because the cause of that hypercapnia is you reducing the tidal volume. Do you understand? So it's better for you to reduce the tidal volume and allow for hypercapnia than to reduce hypercapnia and increase the tidal volume. Do you
Yes.
understand what we are saying?
Yes.
So you can
Sorry,
also
Chief.
yes, Doctor.
Please come on. Yeah. So I just want to understand something. The way I kind of like put it in my head, I thought that once you have a low tidal volume, the respiratory rate will increase, like it works simultaneously.
Mm, yes, but this is like a mechanical ventilator. You are already placing the
Okay.
patient, so you are in
Okay.
control of the rate. You get
Oh, okay, okay,
so the
okay. Makes
patient is not.
sense.
Yes, so that is why. So uh, so that's that about tidal volume. You can also adjust the PEEP to recruit more alveoli. You know that most of the alveoli in ARDS they have collapsed. Increase the PEEP so that you can recruit more alveoli. You can open up more alveoli to achieve adequate oxygenation. So you have to adjust the PEEP and the FiO2, but you don't want to increase the FiO2 more than 0.6 because once your FiO2 is more than 0.6, you are playing with oxygen toxicity. So to increase PaO2, increase your PEEP, increase your FiO2, but don't make it more than 0.6. The goal of oxygenation is to increase it. You increase your PO2 more than 55. So some textbook will tell you 55 to 80, and of course SpO2 more than 88%, always more than 88%. Even in COPD more than 88%, and keep it between 90 to 94. Here, keep your PO2 more than 55. Then you can extubate the patient if the cause of respiratory failure has improved. So the sepsis has improved, you're already having normal blood pressure, the heart rate is stabilizing, no more fever, you know, the patient is requiring less ventilatory support. So you don't need to be increasing PEEP to achieve hypoxemia, to achieve increase normal oxygen. So even with low PEEP, the patient is still okay. You know, that is low ventilatory support. You can extubate. Um, if oxygen supplementation is accompanied without support of PEEP, it's just like the same thing. If patient passes a spontaneous breathing trial, so you try to cut off, you just like remove the mandatory breathing. So because with mechanical ventilation, you are the one controlling the breathing. You set it where you be taking like 12 breaths, 12 cycles per minute. You remove that mandatory breath. You just keep the patient on minimal PEEP to open the airways. Then you see if the patient can actually breathe on his or her own and maintain oxygenation. If you remove the respiratory support, you just apply your minimal PEEP to open the airways. You are not actually, we have two things: ventilation and oxygenation. Your PEEP is to oxygenate, keep the alveoli open. Your breathing cycle, like you moving your chest up and down, that's like ventilation. That's the one that is taking air in and out. So, but the space where the air will come in is what your PEEP is trying to open, oxygenation. Now, what you do is that that upward and downward movement of the chest, you take it off, but keep the airway open by your PEEP and see if the patient can actually breathe spontaneously on their own. So, if they can breathe spontaneously on their own and you measure the PaO2, it is normal. SpO2, fine. You know that, okay, you can actually extubate. But after you have done that and the SpO2 is down, everything is just down, you know that this one is not ready to be extubated. So you return it back. Mechanical ventilation. So mechanical ventilation is the process by which gas is moved to and from the lungs by an external device to artificially support their function. It can be invasive by you putting a tube or a hole in the airway like tracheostomy or in the trachea tube, or it can be non-invasive by using a mask connected to the mechanical ventilator. So that you connect a mask to the mechanical ventilator, or you connect a tube to the mechanical ventilator. If you connect a tube to the ventilator, that is invasive. If you connect a max, it is non-invasive. So an example of non-invasive is what? Our what? Anybody? Our, who knows?
MPPV.
BiPAP,
Yes,
CPAP.
our MPPV. So our BiPAP and our CPAP. So what are the indications for mechanical ventilation? You don't have to cram this. Just quickly list causes of respiratory failure in your head. So respiratory failure is two types: hypoxemia type 1 and hypercapnia type 2. Hypoxemia less than like 50. Hypercapnia CO2 greater than 50. So you have talked about two things: inadequate oxygenation from anything, different causes, or inadequate ventilation. That's the one that will cause type 2 respiratory failure, causing hypercapnia, either from inadequate ventilation or from play chest. The third is inability to maintain airway. So the reason why you are putting in the tube is so that you can secure the airway. Someone that is unconscious, someone that has a trauma, head injury, someone that is with GCS of like 8 or less. And I just had a convulsion. You know that these people cannot maintain their airway, intubate. Then of course, hemodynamic instability. People that are hemodynamically unstable too cannot maintain their airway, so you might need to intubate them. There are so many reasons though for this, but let's just stick with that. So the ventilator mechanics. Let us, round up with this. Or we are not rounding up. We still have stuff to go to. So ventilator mechanics is just talking about the pressures, in the mechanical ventilator and what they represent. So the total pressure to push in here into the lungs is what we call the peak inspiratory pressure, right? That's the total pressure you need to push in. So what are the things you need to overcome? You need to overcome two major things. Number one, you need to overcome airway resistance, because everything starts from the tube inside that person's mouth, right? There's a tube in the person's mouth. The tube is connected to the mechanical ventilator. Then from the person's mouth downwards into the lungs. So of course there's going to be airway resistance as air is flowing in across this circuit. You have to overcome that airway resistance. That is the restrictive pressure. When the air from the mechanical ventilator downward into the person's lung gets to the lung, it has to expand that lung. There is an elastic pressure that you need to overcome to kind of expand that lung. That is elastic pressure. Then to keep it open at the end of expiration, when you have brought the air out, that is your PEEP. So your peak inspiratory pressure must be able to deliver all these three pressures: respiratory pressure, elastic pressure, and your PEEP. Then the next is your play to pressure. So play to pressure is just like, I don't know if you have, yeah. So play to pressure is just more like elastic pressure plus PEEP. Let me tell you why. You only get your play to pressure when you eliminate airway resistance. When you tell the patient when you hold the breath of the patient with your mechanical ventilator, when you hold the breath, there's an inspiratory hold. You have eliminated airway resistance, so you don't need restrictive pressure again. So the pressure to overcome elastic and the PEEP is what you call the play to pressure. So this play to pressure basically helps you to deliver the elastic pressure to expand the lung. So that means that it's helping you to, what's it called? Achieve compliance, right? To achieve more compliance, to overcome that elastic pressure. Because let's imagine that if something has high elastic pressure, it means that it has a very high tendency to come back on itself. What do you think will happen to the compliance of that stuff with high elastic pressure? Anybody?
It will reduce.
It will reduce. So you need your play to pressure to expand the lung to achieve more compliance. So play to pressure is just peak inspiratory minus restrictive pressure, or You can just con it. Once you understand it, you don't need to cram it. You already know that you can only get plate pressure when you eliminate restrictive pressure. So it's going to be, you know, your because your peak inspiratory pressure is plate pressure plus restrictive pressure. So it means that plate is peak inspiratory minus restrictive, or plate pressure can be elastic pressure plus PEEP. Anyone. So it reflects long.
Sorry, please can you just come again with the last two statements I made?
So you know that peak inspiratory pressure equals sum of these three, right? Now, and I
Yeah.
said that for you to get your plate pressure, you have to remove restrictive pressure from your peak inspiratory. Remove restrictive pressure. So what is left is going to be your plate pressure. So
Yeah.
plate pressure is elastic pressure plus PEEP. So if plate pressure is elastic pressure plus PEEP, it means that peak inspiratory equals restrictive pressure plus what? Plate pressure.
It's a problem. Okay.
So plate pressure reflects long compliance.
Okay. Dr. Baba, sorry to take you back. Please, I didn't really understand which one is elastic pressure and which one is PEEP. I'm finding it difficult to get.
Look at the circuit. Look at the circuit. Picture that
Okay.
somebody has a tube in his mouth connected to the mechanical ventilator. That's a
Mm-hmm.
closed circuit. That's a closed circuit, right?
Yes.
Here is going to flow through that circuit, right? So
Mm-hmm.
there is a resistance when here is flowing. You need to overcome that resistance.
Yes.
That
The
is
airway resistance.
airway resistance. So that is, you need to overcome restrictive pressure. That's number one.
Okay.
When the air gets to the lung, it needs to expand the lung, right?
Yes.
That is, you need to overcome elastic pressure. Number two.
Okay.
Number three, when you are moving out the air, you need to keep the alveoli open, right?
Mm-hmm.
So you need to deliver the PEEP. So that
Okay.
means that peak inspiratory pressure is what? Restrictive pressure plus elastic pressure plus your PEEP.
PEEP.
So this is the
Okay.
pressure that you are going to deliver to the lung that will keep the lung
Mhm.
open and can oxygenate the lung.
Okay. So the plateau pressure is peak minus resistive achieved by breath holding.
Fantastic.
Okay.
So plate pressure
Sorry.
is gotten.
Sorry, Chief.
Yes, Dr. Miriam.
I'm so sorry. This so elastic pressure from what you just said now, that means an increase in elastic pressure will reduce the lung compliance.
Yes, that is correct. It will
Okay.
reduce lung compliance. It will reduce lung compliance. That is very, very correct. So now, plate pressure reflects lung compliance. It means that because you know that plate pressure is the one that you need to expand that lung, right? Plate pressure is elastic pressure plus PEEP. It is the one that you need to deliver to overcome this elastic pressure so that you can expand it, right? So it means that if there's something that is reducing the compliance, you need to increase your plate pressure, because it is your plate pressure that will help you overcome elastic pressure to expand it, to to make it stretch. So if the lung has low compliance, it doesn't want to stretch, it means you have to increase your plate pressure to stretch it. So your plate pressure is a reflection of lung compliance. The lower the compliance, the higher the plate pressure you have to deliver. Do we understand this? Or is it confusing?
I understand.
Just know that.
Just application in question.
Just what?
I said just application in question, but I understand
No, no,
up to
it's
this
not
level.
hard. It's not hard. We'll see it in question. We'll look at one question. I think I have one question here. So just know that the way you can measure your plate pressure is to do inspiratory hold. So you eliminate restrictive pressure from the calculation of the peak inspiratory, and you'll be left with elastic and PEEP, and that's going to be your plate pressure. The restrictive pressure is the one resistant to airflow. We have said it. So that will be your PEEP, PIP minus plate pressure. That's going to be restrictive pressure. Can you see that you don't need to cram it? Once the values, you can maneuver yourself. You don't need to cram anything. And the pressure along the ventilator circuit, endotracheal tube, and the airway. The PEEP is the one that keeps it open. at the end, right? So there's what you call the auto PEEP, and so auto PEEP can be measured when you tell the patient to hold. So you are not telling the patient to. The patient is not the one doing it. You are the one that is doing it. So at the end of expiration, you hold it. Then you see what pressure is remaining to keep the lung open. That's going to be your auto PEEP. That is your auto PEEP. That is keeping it open, right? So if a patient has COPD or asthma and there's airway and there's hair retention, what do we think is going to happen to the PEEP? Anybody, just guess. If there's
Sorry,
COPD,
what's your question?
if there's
Uh-huh.
COPD and there's hair retention in the lungs, what will happen to PEEP?
It will increase.
It will
Increase.
increase.
Mm.
That PEEP that is you are dealing with, that one is called the intrinsic PEEP. The intrinsic PEEP. So it's not the
Okay.
normal extrinsic PEEP of normal.
Oh, okay.
So that's what we
Oh,
call
okay.
intrinsic PEEP. Yeah. So elastic pressure, is the one that, so it is due to elastic recoil of the lung. And I told you that elastic recoil is similar to what other force? Anybody remembers? Elastic
What?
elastic pressure is synonymous to which other force? Elastic recoil.
Um, recall. Yeah.
The surfactants.
No, surface tension.
Surface
So
tension. Okay, yeah.
so surface tension and elastic recoil means the same thing. They are acting inwards to collapse that lung. So that means they are acting in opposite direction to what? To compliance. So if a lung has a very high elastic pressure, na problem, because it means it's elastic, like it's recoiling on itself. So and you know that plateau pressure equals elastic pressure plus PEEP. Elastic pressure equals plateau pressure minus PEEP. So anything that can increase elastic recoil, or anything that can reduce compliance, will increase elastic pressure. So what are the things that can reduce compliance? If the lung is stiff from fibrosis, do you think that lung will be compliant? No. What do you think will
No.
happen to the elastic pressure of that lung? High. If the
If it
person,
okay,
do you
go on.
understand that? Yeah.
Yes.
So
A
if,
steep lung.
yes,
Elasticity is low.
yes, exactly. So a lung with ARDS, what do you think will happen to the elastic pressure?
It's lost.
Elastic
It will
pressure,
increase.
it will
Okay.
increase. It will increase. So
With
uh
ARD.
yeah. So if you have kyphoscoliosis, obesity, ascites, all those things does not allow the lung to come out well. So if you are applying pressure to the lung, what do you think will happen to the expansion of that lung? For somebody that has a reduced chest wall size due to kyphoscoliosis, or reduced diaphragmatic excursion due to obesity or ascites, what do we think will happen to the compliance of that lung? Just just guess.
They reduce.
It will
It will be reduced.
reduce. So if compliance is reducing, what do you think will happen to the elastic pressure?
It will
It
increase.
will increase.
Increase.
You can see. Just take your time. You might not be saying it like giving somebody. If they ask you, you might not be saying it spinal level. Take your time to think it through. Pulmonary fibrosis. It means that I cannot expand. Okay, elastic pressure is increasing. Yeah, I need to
I want to
deliver.
understand how. Sorry, I want to understand how the elastic pressure is increased in ARDS.
So, what happens to surfactant in ARDS?
It's lost.
Is washed out.
They
What
are
happens to
washed out.
surface tension?
Is increased.
So, surface tension is synonymous to which other pressure?
The elastic pressure.
Elastic pressure. So, if there's increased elastic pressure, what do you think is going to happen to that lung? Is it going to expand or collapse?
It will collapse.
It will collapse. So, what do you think is going to happen to compliance? If something is collapsing, is it going to be compliant?
No, it will
No.
be reduced.
So compliance reduces. That's
Okay.
the way to look at it.
Okay.
So I know that is a long process of thinking, but with time, when you say
So
it to yourself,
much. Yeah.
you think about it, you become so
Um,
used to it. So this is the cough, inspiration, expiration, you hold, inspiration. No, you just take a while, then you do it again, So this is going to be the cycle, depending on the cycle. So if the cycle is like faster, so this duration will be shortened. So depending on the cycle, then when you get here, you hold it. So this ideally from this place to this place, from this place to this place is your PIP, peak inspiratory pressure. But once you hold it here, right, you have eliminated restrictive pressure. This is restrictive pressure that you have eliminated. So the pressure that's going to be remaining is your plate 2, and plate 2 is going to start from here to here. So here to here is your plate 2 pressure. Because once you hold the bread, the pressure will equilibrate, and the pressure that will be remaining for you to overcome will be the elastic pressure. And from here to here is your elastic pressure. So this is going to be your PEEP. So this level here is our PEEP. So PEEP plus elastic pressure is going to be our plate 2 pressure. So if you're adding restrictive pressure, you are going to get your peak inspiratory pressure. So here to here, the force you are overcoming is airway resistance here. Here to here, force you are overcoming is what? Elastic pressure. So that is the pressure you are trying to overcome. So that is that. So let's see how the waveform will be in pathology. If you get this image in your exam, you should not be scared at all. You see, the first thing you just go and look is that, okay, they have given me the normal what's it called, curve. This is the normal curve. The blue line is the normal curve, right? The elevated one, the red one, is what? The abnormal curve. Now look at it. Which curve do you think is elevated? Is it the plate 2 or the peak inspiratory pressure? Which one is elevated in this one?
The peak inspiratory.
The peak inspiratory. So there's nothing affecting the what's it called? There's nothing affecting the plate 2 pressure. So we can say that the compliance of this lung, is it okay or not?
It is reduced.
No. See, look at my question. There's nothing affecting the plate 2 pressure. The plate 2 pressure is fine. The only thing that's elevated is your PIP. So, do you think there's problem with the compliance of this lung?
No. Okay.
No. It means that this is not a compliance problem. And what is the only thing that separates plate 2 pressure from PIP, from PIP?
The resistive
pressure. So it means that there's a problem with the resistance here. The problem can be two things. Either there's a problem with the resistance or the problem with the the compliance. So if it's a problem with the resistance, it will not affect plate 2. Plate 2 doesn't have any business with resistance. Plate 2 is only compliance or elastic issue. That's plate 2. Restrictive is, going to affect the PIP, because PIP takes the 3. Your restrictive, your elastic, and your what? Your PIP. So the next thing for you, once you just see the elevation, the next thing for you to just quickly do is that, okay, check the plate 2. Is it okay? Plate 2 is okay. Oh, this one will be compliant. So this is resistance. But what can be occluding, like the circuit? Is it that the tube has kinked? Is it that there's mucus plug somewhere? Is it that there's bronchospasm? Is it that the tube is narrow? So you just look at the individual's airway. Is it bronchospasm that is narrowing? Is it that the tube is narrow? Is it that the tube is kinked? Or is it that there's a mucus plug that is there? Very easy. Increased airway pressure. Now, you go down again. You can see that PIP is elevated. Good. But at the same time, plate 2 is elevated. So it means that there's a problem with compliance here. It means that there's a problem with compliance. So, what do you want to think of? Why is this lung not stretching now? We have to now be stretching the lung by applying elevated plate 2 pressure. Why is it not stretching? Why is it collapsing? Is it that the person has ARDS? Is it that the person has atelectasis? Is it that we are not intubating the right lung we are supposed to intubate? If you go and intubate one bronchial and you leave the other one, it is only one lung that will be expanding. The other one will appear as if it has collapsed. So watch out. Main stem intubation. If you go and intubate a broker, instead of putting your tube at the cariner where the where the tracker bifurcate, you can put it in one main stem broker. It's going to show reduced compliance. Atelectasis can show reduced compliance. Pulmonary edema is the same thing as ARDS. Both of them have pulmonary edema. They wash out surfactant. There's going to be reduced compliance. Pneumothorax. If there's air in the lungs, do you think the lungs will be able to? If this is the cavity, the pleural layer surrounding the lungs, and this is the lungs, and there's fluid here, there's air here compressing on the lungs like this, do you think the lungs will be able to expand? No. The compliance of the lungs will drop. So pneumothorax can also reduce compliance and can increase the platelet pressure. Let me see if I have a question here so that we can just. I don't know if I have a question. Or more. And I think the last time I did this thing, there was a question. There's no question. Jesus Christ. I showed us a question that last time. But I don't have it. What do we do now? There's a question on U-word actually. There's a question on U-word that actually tests this concept.
If I see it, I will post it. So, just in case, in questions, that means that if they're giving us this kind of graph or diagram, they will put both the normal and the abnormal.
Definitely. They put both the normal and then you identify where the problem is. So once you identify the problem, you just treat accordingly. So they will give you a list of options. If the problem is reduced compliance, they might narrow you to king alveoli and they'll put main stem intubation there. So you already know your answer. So for the ventilation setting, you want to do what we call volume. Most of the institutions do volume assist. So with volume assist means that you are delivering a particular volume, a tidal volume. That's what you are delivering. But you are watching out for changes in the pressure. So it's the best. I think I like that. So you deliver a certain volume of tidal volume and you watch out for changes in pressure because compliance equals volume over pressure. So once there's any change in the pressure, I will detect it. The machine will tell me because it starts beeping. What are the pressure changes that can happen? Your PIP can increase, your platelet pressure can increase. So the machine will start beeping. Bang, bang, bang. You quickly go and check what is happening and you know the cause. So you set your tidal volume at 6 to 8 in obstructive lung disease. You set it to 6 in ARDS. The reason why you are setting to low volume in ARDS, we have said it. People with ARDS or any restrictive disease, they cannot expand to filling with hair, right? Because of the low compliance. So it means that you need to increase the respiratory rate, right? To get the ventilation done. So you don't need to increase the volume. If you increase the volume, you can rupture them. So just keep the volume low and increase the respiratory rate. But for obstructive, the problem is that they find it very difficult to take air out in expiration. So what do you have to do? You have to prolong the respiratory phase. What do you do to prolong the respiratory phase? So instead of you increasing the respiratory rate to 20 cycles per minute, why not drop it to 10? So that, now let me tell you something. If you have, if a patient is doing 10 cycles, if a patient is doing 10 cycles per minute, it's better. If a patient is doing 10 cycles per minute, it's better than a patient that is doing 20 cycles per minute in terms of the duration. In that same 10 minutes, in that same 1 minute, you are doing 20 cycles. In that same 1 minute, this person is doing 10 cycles. It means that for this person to be doing 10 cycles in 1 minute, it means that the time he's spending in expiration and inspiration is much more than the person that is doing 20 cycles per minute. Do you guys agree with me?
Yes.
So reduce the respiratory rate so that this person will have more time in expiration to actually take out the hair. So that is why in obstructive lung disease, you reduce the respiratory rate and you increase the tidal volume. So that's why you are using 6 to 8. You can use 8. But restrictive, you must drop the tidal volume drop it to 6 and increase the rate. So if you want to know it, restrictive R, increase respiratory rate, drop tidal volume. Obstructive, from the analogy, reduce respiratory rate, increase tidal volume. So the rate is set lower, just like what we have said. The rate is set lower for obstructive lung disease as opposed to ARDS, e.g., 10 to 14 in obstructive. You have to use low rate. Why use 14 to 18 in ARDS? You don't have to be a genius to know this. These are stuff you can see in your exam. So FiO2 is started at 100%, then you titrate it down to what? To less than 60. Do not keep your FiO2 more than 60. It is dangerous because of oxygen toxicity. What are you trying to achieve at the end of the day? You want to maintain a PO2 within the level of 55 to 80 and your SCO2 within 88 to 95. Don't forget.
Fifth, there's a question that Dr. Joy posted on the chat.
On the chat, Abi?
Mm.
Okay. Let me check it on my phone.
No, like the Google chat here, not WhatsApp.
Okay, the Google chat. Oh. Let me see. There's a way I can view it. How can I view that?
No, the next one close to that icon. No. Where you clicked to show this.
Is it this?
No. Where you clicked to show the list of people on the.
Okay. Oh, thank you.
Yeah.
Oh, thank you, Dr. Joy. But the only problem here is that this is not showing the graph. Now you see that graph is what I'm interested in. But let's see this. A 46-year-old man is hospitalized due to severe pancreatitis. Because of progressive respiratory difficulty, he is intubated and placed on mechanical ventilation. Okay, the weight is this, blood pressure is this. Chest X-ray show party opacity bilateral. His ventilation setting are assist control mode. Okay, respiratory rate 18, tidal volume 450. What's the weight? Did they give us the weight? 150. We have to be converting laps to kg. What the hell? FiO2 is 40. This FiO2 now we can increase it. PEEP is 5. Okay, his blood gas reading pH of 7.5, so this is alkalotic. PCO2 is 22, so it does mean that this patient is having respiratory alkalosis. So it means that this person is hyperventilating. So PO2 is 69. What's the best next step? Okay, so Dr. Joy, is this the only thing? So we have to increase this guy's PO2 rather, pressure of oxygen, and we know that two things we can do: increase your PEEP or increase your FiO2. Dr. Joy, are you sure this option is complete? We are just seeing two options though. No. Decrease respiratory rate and decrease FiO2. You can't decrease the FiO2. Never. You have done nothing. If you decrease the respiratory rate, this person is having restrictive lung disease because there's likely to be pulmonary edema. So in people with pulmonary restrictive lung disease, you want to increase the respiratory rate so that you can, and if you decrease the respiratory rate, you can actually elevate the CO2, right, to take out the respiratory alkalosis. But what will happen to the oxygenation? I don't want to think that. So the answer is
Dr.
decrease
Baba,
respiratory rate.
okay, sorry, I wanted to ask a question.
Yes, Doctor.
I wanted to ask, what should be the normal value for the PEEP?
For the PEEP.
I know FiO2 will not be more than.
I don't know the normal value for the PEEP, but you don't want to. The one that they usually talk about is the platelet pressure. You don't want to keep your platelet pressure more than 30.
More than 30.
Yeah. So, Dr. Joy, maybe the answer, if we are to pick in between the two, we will definitely pick decreased respiratory rate, because this guy has respiratory alkalosis, right?
Yeah, I think so.
And the CO2 is already coming down, so you need to decrease the respiratory. I can bring it up, but how will you have this person's hypoxia? ideally they're supposed to either increase the PEEP or increase the PiO2 to improve the hypoxia, but that's fine. The hypercapnia too, the hypocapnia too can be a problem. So I think that's what they are trying to test. Okay. So this patient has pancreatitis, has RDS. Uh, but if the patient fails to breathe as well, then the ventilator going to deliver tidal volume. In general, the TV show was 6 millimeters. Okay. Yeah, that's fine. That's fine. So the thing is, we just look at both sides. So if we are not, but the major thing is to focus on the oxygen. If you are not getting any option that talks about improvement of the oxygen, like here now, the one that will have favored oxygen is FiO2, but we cannot decrease FiO2, so this one is out. So then you can now look at the PCO2, because this guy is having two problems. He's having hypoxia, and it's not, well, it's not really hypoxia because of it's not in respiratory failure yet because it's not less than 60, but there's still hypoxia, and the PCO2 too is low. So you can do an intervention to increase the PCO2 and also to increase your oxygen. So does anybody want to share their word?
Reducing the respiratory rate, yes, I agree, can help to increase the PCO2, but would that also increase the PO2?
Yeah, that's what I'm saying, Dr. Antonia. Like, this question is not actually to the adjustment continues. Do you understand, Dr. Antonia? You do that to correct for the PCO2, but you also need to adjust for this FiO2 or PEEP to compensate, to correct the PCO2. Do you understand? So you have to do those adjustments like that on the mechanical ventilator, but they did not put the option for those ones here. So the best one to pick is for the PCO2. If anybody can share their word, there's a particular question in word that shows the, what's it called, the graph that we can use to anybody want to help us?
We can't share it online world. It won't show.
Okay, unless you go through browser. That's stress.
Yeah.
Don't worry. So let's go. So now, so you set your PEEP and tell for this is to prevent viral time. Yeah, so you don't want to over PEEP the patient. So just keep it within like 0 to 5. Start with PEEP of 0 to 5, then you can increase it gradually, and you have to be adjusting it with the FiO2, but you have to make sure that you're not over PEEPing so that it doesn't burst. Then another thing you need to adjust, aside adjusting the rate, aside adjusting the FiO2, aside adjusting the PEEP, is to adjust the IE ratio. So in people with obstructive lung disease, you want to increase the respiratory time with respect to the inspiratory time. So it has to be high. So this one now for obstructive lung disease, because they need more time in expiration, so you have to make sure that the inspiratory expiratory time is greater than 1:3. Why in ARDS it is not obstructive, so keep the expiratory time lesser. So 1:15 is fine. So this is needed because the lungs takes more time to effectively empty due to obstructed airways. Okay, we already know this adjustment. So exactly, Dr. Joy, this is what Dr. Joy just showed us now. If this is the abnormality, reduce PCO2, what do? Increase PEEP, increase FiO2. If reduce PCO2 is the abnormality, we can see that one now, reduce PCO2 was the abnormality. Can you see? So what do? Reduce any one of these. Now, if increase PCO2 is the abnormality, increase any one of these. So that is it. So, complication of mechanical ventilation. So, a lot of them. There could be volutrauma. Volutrauma means you have given too much tidal volume and it can burst. So, this can be prevented by using lower tidal volume, particularly in people with ARDS. Don't forget ARDS. The next is barotrauma, high pressure. So, like peeping, over peeping, or using increased play to pressure. So, keep your platelet pressure less than 30 so that you don't borrow trauma the stuff. So in ARDS, a long protective strategy is to keep your platelet pressure less than 30. Another long protective strategy is to keep your FiO2 less than 60. Very, very important. So atelectrauma is due to cyclic opening and closing of the alveoli. So this can be minimized by increasing your PEEP. Do you know why? Because if you increase your PEEP, there's a very high tendency that the alveoli is already open. So you don't need to be open and closing, open and closing. So because this is mediated by the driving pressure. The higher the driving pressure, the more the cyclical opening and closing of the PEEP. So just keep your PEEP open so that you have a lot of alveoli open and you don't have to be closing them, opening them again, which can lead to atelectrauma. So biotrauma can occur from any one of these, and that's just due to release of inflammatory mediators that's going to lead to damage of the alveoli with time. Then the last is oxygen effect. Possibility of high FiO2 causing lung damage, and this is likely when the FiO2 is less than 0.6. Yes, Thompson, come in. So you don't want to increase the FiO2 too much so that you don't generate too much reactive oxygen species. You don't cause inflammation and edema, and you don't destroy the lungs totally. So key fact to know is that in left heart failure, PEEPing is beneficial. Why? Because if you PEEP, you will increase intrathoracic pressure. What happens when you treat intrathoracic pressure after PEEPing? You will compress the pulmonary vein, and of course you are going to deliver less blood to the left side. So if you deliver less blood to the left side, that means that you're using the preload, and you help the person with the left heart failure. I know we usually have a problem here, but do we get this? Because I usually struggle with this.
Please take it again. Yeah,
I know. So if the patient has left heart failure, you know that what you want to do is to reduce the preload, right?
Yes.
PEEP that guy. If you PEEP that guy, you increase the intrathoracic pressure, you compress the pulmonary vein. When you compress the pulmonary vein, what happens to the preload that is delivered to the left side?
It will be reduced.
It will be reduced. Do you think you are taking the person out of heart failure? Are you not taking the person out of heart failure?
Yes, you're taking.
Why do we give furosemide in a patient with heart failure? You reduce the preload.
Sorry, can you just repeat that last rationale? Sorry, I wasn't paying attention. Sorry.
You PEEP the patient. If you PEEP the patient, you are keeping the lungs open. You are increasing intrathoracic pressure. You are kinking the pulmonary vein.
Yes.
If you kink the pulmonary vein, what will happen to blood flow to the left side of the heart?
It will decrease.
Are you helping the patient with heart failure or not?
You are helping.
You are helping. But you don't want to PEEP someone that has right heart failure. Why? If you know that if you PEEP, you are increasing intrathoracic pressure. That pressure is squeezing the pulmonary artery, the pulmonary capillary, and the pulmonary vein. And all of them will prevent emptying into the left atrium. Now, if you over PEEP again, and you increase intrathoracic pressure, and you squeeze the pulmonary artery, pulmonary capillary, and the pulmonary vein, what will happen to the afterload to the right side of the heart?
It will increase.
It will increase. Do you think you are helping that person with right heart failure?
No, you are worsening it.
You are worsening it. So, PEEP is beneficial in left heart failure. PEEP is worse in right heart failure. Very, very easy stuff. Very, very.
So, in other words, PEEP reduces preload in left heart failure, and then increases afterload in right heart failure.
Correct. So that is why.
Sorry.
Dr. Mariam.
Sorry, maybe I'm mixing it up in my head. I thought that a patient with left heart failure has reduced cardiac output.
Yes.
Okay, so why do you not want to reduce the preload?
No, but you know that. No, the thing is, treat the cause of that left heart failure. Maybe the person has coronary, like MI, that's not allowing the heart. You know, the reason why the heart cannot contract is not because of the preload that you are, increasing or reducing. No. The problem why it cannot contract is an intrinsic problem with the heart. Maybe the person has MI. So treat the MI. The person will be able to pump out. Do you understand? But why
Yeah.
you are waiting interim to treat the MI so that the person can be pumping out? You also want to reduce congestion in the pulmonary circulation that is causing dyspnea.
Okay.
So reduce the preload. Because just imagine somebody is having left heart failure, Dr. Miriam. You are now increasing preload. Heart will not fit pump blood before. You are now bombarding preload. What do you think will be happening to that preload? It will be going back to the pulmonary circulation and the person will become
Yeah.
dyspneic.
Okay. Okay. I get.
So that is what your PP is doing. So so your PP is not actually going to give you a definitive cure, but it's just going to give you a symptomatic relief. You still have to treat what is causing that problem. So for acute brain injury like stroke, target SpO2 of 94 to 98, or you keep your PaO2 between 80 to 100, to help the brain oxygenate. Both very high PEEP and hypoxemia can cause increased intrathoracic pressure and can cause cerebral ischemia. So what they are talking about here is that if you PEEP the patient, right, and maybe there's long collapse at the end of the day from barotrauma, the patient becomes hypoxemic. If the patient becomes hypoxemic, autoregulatory mechanism in the brain, the vessels becomes vasodilatory. They want to take in more oxygen. When there's vasodilation, we rush blood flow to the brain vessel. Intrathoracic pressure, intracranial pressure increase. And you know that intracranial pressure, is against cerebral perfusion, according to that mean arterial pressure, blah 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 formula. So the more your intracranial pressure, the more the pressure that will be compressing on the vessels. So you are going to have cerebral ischemia. So that's why you don't want to increase intracranial pressure too much, because of the fact that the pressure can actually compress on the vessels and cause cerebral ischemia. So do we
I
understand
beg
that?
this one no enter. I beg. There are a lot of things here. Oh. This one no enter at all. Please, you said an acute brain injury. You said an acute brain injury
So if a
stroke.
patient has a stroke, there's
Yes.
there's the brain is already having some issues. So now
Yes.
you don't want to be over peeping that kind of, because you place that person on mechanical ventilator, right?
Mm-hmm.
So because of the protection of the airway. Now, if you
Mm.
over peep that kind of patient,
Mm-hmm.
there's a tendency that there's going to be barotrauma and
Yes.
there's hypoxemia from there.
Mm-hmm.
Now, if
Okay.
there's hypoxemia, the blood vessels of the brain kind of react to hypoxemia by vasodilation. So you have increased
Yes.
blood rushing to the brain. That
Okay.
increased blood rushing to the brain will increase the pressure within the compartment of the brain. So it's going to
Mm-hmm.
compress on almost all the vessels in the brain, both the dura venous sinus, the capillaries, the arteries. And at the end of the day, there's going to be cerebral ischemia.
Mm-hmm.
Do you get it?
Yes.
So that's why you don't want to over peep in somebody with stroke. So just by the way, you can think it through in the exam, even if you forget. Just think it through. High peep is definitely going to cause hypoxemia from barotrauma. So you can take it off from there.
So you maintain their
Mm-hmm.
said you maintain their SpO2 saturation at 94% to
Exactly.
98%.
Yes.
Mm-hmm.
So
That's almost
yeah. So a patient with mechanical ventilation and suddenly develops acute hypotension, what are you thinking of? You are thinking of tension pneumothorax. Why? Because if a patient is on mechanical ventilation and you over peep and there's barotrauma or there's a volutrauma and sorry, I think I'm missing something. Sorry, there's something I need to say. Acute temperature with tachycardia can cause a tree. Okay, yeah, I get it now. Okay, yeah. Sorry, I was lost. So, part of what can cause. So, what they are talking about here is that you suddenly see acute hypotension in a patient on mechanical ventilator. Now, you need to quickly look at the pressure changes in your mechanical ventilator. If you see that there is a sudden peak in your PEEP and there is hypotension, think of tension pneumothorax. Why? Out of all the causes, of increased PEEP without affectation of the platelet pressure, meaning the problem is compliance, it is only pneumothorax that can cause hypotension. You can check it yourself. I know that somebody will say pneumonia now causing sepsis. They can be try to link everything together, but acutely, a patient that has a mechanical ventilator that was initially stable and suddenly develops increased PIP with normal, increased PIP with increased play2, and becomes hypotensive. Think of pneumothorax, because if there's pneumothorax, the compliance will reduce, play2 will increase, PIP will increase, and pressure will also drop because of the kinking from the pneumothorax. Tension pneumothorax, mediastinal shift. You kink the IVC. IVC will reduce delivery to the right. From reduce delivery to right, it will reduce delivery to the left, so there's going to be hypotension. Do you understand that? There's no way atelectasis will cause hypotension. There's no way men's intubation will cause hypotension. There's no way pulmonary edema will cause hypotension. So, do you get that analogy?
Yes.
So
for a patient on mechanical ventilation, suddenly develops hypotension, think of tension pneumothorax.
yes, think of because definitely you are going to, in addition to the hypotension, watch out for increased peak respiratory pressure and also platelet pressure. So think of tension pneumothorax. Also, you can have some things that can cause decreased venous return. We have explained that if you PEEP, you are going to increase intrathoracic pressure, coronary vein, and the venous return to the left side of the heart will reduce, and that will exacerbate hypotension. Sedative and opioids in ventilation patients too can cause hypotension. My people, I am so exhausted. I think
we understand. It's really so much, honestly.
we need to take a break. We need to take inspiratory hold at this point. Honestly speaking, I'm so tired. But do we have any question? God.
Yeah, I just wanted to ask you. I don't know if you'll be able to do that though. Otherwise, it should be maybe when you're good to kind of a summary of management of acute respiratory distress, ARD. A summary of it all. So mainly giving you have to give oxygen, prone position, because there are a lot to it. I just want kind of a summary of it, not that I don't understand it. So you give IV fluid and the treat underlying diseases.
Yes.
Then you give oxygen by mechanical ventilation.
Then the prone position. You are talking. Hey, sorry. With all these things you are saying, what is the summary you now want me to give? You have said everything. You have said everything.
So okay, and then the prone positioning. So this FiO2, he said prone positioning if the POA2 FiO2 is less than 150, right?
Yeah.
And then FiO2 greater than 60%.
FiO2 should not be more than 60. FiO2 should not be more than 60. Do you get it? You start from 100, titrate it down to 60.
Yeah, titrate it down to 60.
To less than 60, yeah. So
okay, should be less than 60.
So patient comes in, ARDS, do your workup, collect your sample, set your IV line, give your oxygen. If there's a need for diuretics, give your diuretics. Comment your oxygen, check calculate your FiO2 ratio, blah blah blah. If the patient doesn't actually need mechanical ventilator, you might not be doing your FiO2 blah blah. But if the patient is very very unconscious, then intubate. Then that's when you now start doing mechanical ventilator adjustment. So all those things we were saying, they were mechanical ventilator adjustment. Sometimes you might need to put them on prone position if the FiO2, if the PaO2 FiO2 ratio is less than 150. Prone them so that you can recruit the dorsal alveoli. If the mechanical ventilator, adjust FiO2 and PEEP to increase the oxygen. Adjust respiratory rate and tidal volume to increase the ventilation and control CO2. So, depending or whatever is there. So all those things are called long protective strategy. You can see it in your exam. So what are the long protective strategy? What long protective strategy do you want to employ for this patient? Number one, keep your platelet pressure less than 30. Now, keep your FiO2 less than 60. Keep your tidal volume to like 6. You don't want to increase your tidal volume. You don't want to cause volo trauma. Do you get? Because you are dealing
Yes.
with ARDS. ARDS, you don't is a respiratory disease. What you do in respiratory disease is to increase respiratory rate, not tidal volume. So keep your tidal volume to 6. Long protective strategy. And by the time you are keeping your tidal volume to 6, you are going to allow for permissive hypercapnia. Long protective strategy. Another person will see permissive hypercapnia in the exam. You will think patient is dying. That's greater than 45, and you go and pick something else. Don't be disturbed. Permissive hypercapnia is part of the plan to allow for you to deliver low tidal volume. Long protective strategy. What else is there?
Then you said the peak is less than 30 cm.
Yes, keep the plate
pressure. Okay.
Yes, less than 30. Keep the plate less than 30. Yeah.
I'm just trying to organize this whole stuff in my brain.
Yeah.
Okay.
So
that's a whole lot.
The Resp, Abby? Yes.
Huh?
You said the Resp is a lot.
Yeah, I said there's a whole lot here.
Yes.
I need to get in my brain. A whole lot.
You can just, look at them gradually and, pay attention to the important stuff and you'll be fine. I feel Resp is still a little bit easier compared to some of those systems. So it's just to know the stuff you need to know. Once you have them in your fingertips, there's no way they can twist that question. You get it. I can assure you. You get it. So I'm so sorry. Honestly, I plan to take it more than this, but
that's okay. It's fine. Me myself, my head is full. Most of them are full.
The stuff is so exhausted. We'll continue from here. Probably on Thursday. I think the government will take us maybe Tuesday, Monday. I'm not really sure, but it's going to take us before.
I think he said Monday because this weekend he's taking the step ones. I think the next class he said will be on Monday. So
okay, that is fine. I'll look for a way to compensate for the one that I did not record.